हेलो फ्रेंड्स, आज हम बात करेंगे एसिटामिनोफेन और एपीएपी और पैरासीटामोल पॉइजनिंग। एज वी नो कि जो पैरासीटामोल है दैट इज द मोस्ट वाइडली यूज एनाल्जेसिक्स और एंटीपायरेटिक्स इन पीडियाट्रिक एज ग्रुप। अगर हम टॉक्सिक डोज की बात करें तो टॉक्सिक डोज इफ सिंगल डोज is more than 200 milligram per kg. Single dose of more than 200 milligram per kg per day is toxic dose. Adults में, this is in case of children, और adults में single dose of 7.5 to 10 gram is toxic. There is something called as chronic poisoning. अगर repeated administration हो paracetamol की at the supratherapeutic dose at the rate of 90 milligram per kg per day consecutively for few days, then you'll say ki this is chronic poisoning, right? Then you'll say it is chronic poisoning. Therapeutic doses, right? At therapeutic doses 15 milligram per kg per day, right? 5% of this paracetamol is metabolized by cytochrome enzyme P450, which is actually cytochrome P2E1. It is metabolized to N-acetyl para benzoquinine amine, which is highly reactive intermediate. It combines with the glutathione and it forms a non-toxic mercapturic acid, right? Mercapturic acid, and it is then excreted. Now what happens when paracetamol either at the toxic dose, which is more than 200 milligram per kg per day, or when at supratherapeutic doses of 90 milligram per kg per day for few days, right? For consecutive days when it is given, what happens? The paracetamol, it is metabolized to cytochrome P450 to N-acetyl parabenzoate. There is more amount of this. So some of it combines with the glutathione, but and forms mercapturic acid. But the one which is left behind, it has no glutathione stores to combine with. So once glutathione stores are depleted, it rises, right? When it rises, then it produces the sign and symptoms, right? It causes hepatic injury. It then causes hepatic injury, right? Now, what are the stages of paracetamol toxicity following the paracetamol poisoning? How much hepatic injury and necrosis it causes? There are 4 stages: stage 1, stage 2, stage 3 and stage 4. In stage 1 is initial 0.5 half hour to 24 hours of ingestion. Here what happens? There is nausea, there is vomiting and there is anorexia, right? Lab tests are initially normal. Lab test means LFT. AST, ALT are initially normal, but acetaminophen levels may be elevated, right? Stage 2 is between 24 to 48 hours. Here what happens? There is resolution of these symptoms of nausea and vomiting, but there is a pain in the right upper quadrant. There is tenderness and there is pain. Along with that, there is rise in the AST levels, and AST level rises more than that of your ALT level, followed by your INR. Right? Then stage 3, which is between 3 to 5 days of ingestion. In this stage, there is peak level of AST, peak levels of transaminases, and there is development of acute liver failure. And multi-organ involvement is there. Multi-organ failure is also there, right? At this stage, this is the stage which is actually very crucial. From this stage, either recovery occurs or patient deteriorates or death occurs, right? Then stage 4, which is from the 5 days to 2 weeks. 5 days to 2 weeks. Here what happens in case if the patient recovers after 5 days, there is resolution of LFT by 2 weeks. So by 2 weeks, agar in case patient comes with the paracetamol poisoning, you'll call the patient after 2 weeks and you'll repeat the LFT, right? So there is resolution of the LFTs. Patient's clinical recovery occurs, and clinical recovery usually precedes the histological recovery, right? Patient improves clinically, and thereafter patient pathological changes, hepatic injury and necrosis, it improves later on, right? So in case of the ingestion of the toxic amount of paracetamol, that is more than 200 milligram per day, right, or more than 90 milligram per day for few days, per kg per day for few days, then patient reports to you. What do you have to do? अगर patient जो है वो less than 4 hours में report करता है, that is obviously not in case of your chronic ingestion, it is in case of acute ingestion. अगर patient acute ingestion के बाद within 4 hours report करता है तो आपने APA, that is acetaminophen levels have to be sent at 4 hours. अगर patient within 24 hours or thereafter भी report करता है तो you have to send, as soon as the patient comes, you have to send the stat acetaminophen levels. The prognosis is better if the treatment is started within 8 hours of ingestion, right? Better prognosis if treatment started within 8 hours of ingestion. Along with the stat levels of your acetaminophen, you have to send the baseline samples that includes LFTs, CBC, blood glucose, and your coagulation profile primarily, right? Now what happens? Now how we'll manage a case of paracetamol poisoning? If there is a single toxic dose ingestion of paracetamol and time of ingestion is known, we'll follow a nomogram that is called the Rimac-Matthews nomogram. Now, this is Rimac-Matthews nomogram. It is to be used when patient reports within 24 hours of the single acute ingestion with the known time of ingestion, and you have acetaminophen levels with you and AST and ALT levels are normal. Now further treatment decision depends where the level falls on the Rimac-Matthews nomogram. So this is a graph showing the horizontal bar which represents the hours after ingestion of the toxic dose, and the vertical one which represents the acetaminophen levels in the blood. There are two solid lines. The two solid lines, in between the two solid lines, it represents the possible hepatic toxicity. Below this is no hepatic toxicity, and above this is probable hepatic toxicity. So further treatment decision depends upon where your level falls on Rimac-Matthews nomogram. Now, based upon the levels on the Rimac-Matthews nomogram, if the treatment is indicated, we'll start with the NAC, N-acetylcysteine. There are two options. One is oral and another is IV. Oral is less tolerated in patients, those who have nausea, those who have vomiting, and moreover it has got the metallic taste, so there is less acceptance by the children. So mostly we use the IV dose which is available by the name of acetaminophen, right? We'll start this IV NAC for initial period of 24 hours, ठीक है, right? फिर हम क्या करेंगे? At the end of 24 hours, we'll get again the levels of acetaminophen and AST and ALT done. अगर acetaminophen levels are undetectable, there are no more acetaminophen in the blood, and AST, ALT levels are normal, then after 24 hours you will stop the treatment. Second condition is, if irrespective of the acetaminophen levels, if AST levels are rising, then you have to shift the patient to the second category of the treatment, right? You have to increase the category of treatment. Now, third criteria is when acetaminophen levels are still detectable, right? And irrespective of your AST and ALT levels, you have to continue the treatment till the levels are undetectable, right? Now there is another condition. If AP like acetaminophen levels are detectable, right? But AST is normal. But time of ingestion of the paracetamol is not known. Now what you have to do, you have to continue the treatment. You have to continue IV NAC till your acetaminophen levels are undetectable with normal AST levels. So what is the basic protocol for management of paracetamol poisoning? What happens as soon as the patient reaches in the hospital, what you have to do, you just have to take the baseline samples along with the acetaminophen levels. Once the patient is sure that the child has ingested toxic levels, you will start empirically NAC, right? After withdrawing the samples. But further decision regarding the continuation of the treatment should depend upon the reports only, right? Usually what happens in paracetamol poisoning, there is rise in the AST, and the rise in AST is more than that of the ALT, and then it is followed by the raised INR. So now how we'll give the treatment actually. Earlier we discussed what is the protocol and how we'll go about the treatment, right? Now we'll discuss what is the treatment actually and what is the dosage of NAC. So antidote for paracetamol poisoning is your NAC and acetylcysteine. Two forms are available, IV and oral, and you'll decide based upon the condition of the patient. First of all, we'll discuss IV NAC, which is most commonly used. It is also known as anticadote, right? It is available in the form of 3% solution and it is given in 5% of dextrose. So it is of choice in patients who are symptomatic, who have the signs of hepatic injury. Patient is having nausea, vomiting, there is pain in abdomen, there is dearranged lefties, and there is pregnancy, right? Now what is the dose? First is 150 milligram. 150 milligram per kg will give over 1 hour, right? Then followed by 50 milligram, right? This 50 milligram per kg over 4 hours. Then followed by 100 milligram. 100 milligram per kg over 16 hours. And then further continuation of the treatment actually depends upon your levels of acetaminophen and your AST levels. Now there is one very important thing. As soon as in some of the cases, as soon as we start the IV NAC, there is an anaphylaxis, right? There is an anaphylaxis reaction, and that is basically non-IgE mediated. It is non-IgE mediated. Okay? It is a response to the loading dose. What you have to do, anaphylaxis, you know, will be profuse sweating, there will be fall in the blood pressure, there will be fast breathing, there will be tachycardia, there can be urticarial rash and all those things, right? So you have to stop the infusion. You have to stop the infusion. You have to give the epinephrine, right? You have to give Avil. You have to give albuterol, right? And then thereafter, after the sign and symptoms of your anaphylactic reaction settles, you have to restart. You have to restart the infusion at slower rate, right? At slower rate. Now second is oral NAC. Oral NAC is available with the name of mucomist. Right? It has got very unpleasant taste and smell, and in case if indicated, it has to be given mixed with the fruit juices to children, and it can't be given in those who have vomiting, right? Nausea, right? Now what is the dose? The dose is 140 milligram per kg is your loading dose, right? Then orally you are giving 140 milligram per kg is the loading dose you are giving orally. Then 70 milligram per kg 4 hourly. You are giving it till your paracetamol levels, acetaminophen levels are undetectable. Now once the patient is on NAC, you have to monitor LFT, RFT, the coagulation profile on daily basis, right? Now what is the criteria for liver transplant in paracetamol poisoning? You have to follow King's College criteria, right? So there are 5 things that you need to consider. One is your acidosis. If pH is less than 7.3, despite of the adequate fluid resuscitation, right? Second is your coagulopathy. Coagulopathy with INR of more than 6. With INR of more than 6, there is renal dysfunction. There is renal dysfunction with creatinine of 3.4. With creatinine of 3.4 milligram per deciliter, right? Then if there is grade 3 or grade 4 hepatic encephalopathy, right? Then if serum lactic acid is more than 3, serum lactic acid is more than 3 millimoles per liter despite of the resuscitation, you will consider the patient for liver transplant.